This session will be presented by Olaisen. He's an adjunct professor at San Jose State University, and he also consults with community health education as an advocate, as you see in the title of his presentation, for moving aquatic exercise into all aspects of health and wellness. So Ro's presentation is titled Aquatic Expansion into Health and Wellness, Need for Evidence-Based Practice Adoption. Please help me welcome Ro to our group.
Thank you so much. And thank you all for being here. Hope we're going to have a good time together for this next hour. I'm expecting a few people to just trickle in throughout time, but I want to first start by saying thank you so much. Specifically, thank you to the National Swimming Pool Foundation for believing in the work we do and really furthering our field. Bringing together people, I don't know about you, but at this conference within the first 2 hours, I had the opportunity to network with some of the key leaders in our field. I had the opportunity to be inspired in the opening session, and I had an opportunity to learn. And so this is really a wonderful conference, my second time being at it. So let me start then by saying what the objectives are. Really just two things. I'm trying to have you stimulate new thinking and also adopt new processes. So in order for me to tailor the conversation as much as possible to who you are, can we show by show of hand, if you only had to put yourself into two categories, the category one being a practitioner, meaning you can be an aquatics director, operator, anything in the practitioner field, or are you in the research field? So if you only could choose two categories, which one would you fall in? So by show of hands, how many researchers are there in the room? 4, 5. How many practitioners? Yes. And so I am a practitioner too, and this presentation and my research is focused on just that. There is such a divide between the world of academia and the world that we operate in. I'm an aquatics director at a warm water therapy pool in Palo Alto. And so I came into the field of research because everything I read was like, this doesn't make sense. It's too complex what we're trying to do. Researchers look at things too small. RCTs, randomized clinical trials, aren't fitting for what we're doing. So I kept asking myself all these questions over years. And at the end of the day, I stumbled upon community health education. And this is a wonderful field that I hope I will pass some knowledge on to you that I have learned from researchers like Dr. Dial and Dr. Nolan I met yesterday. It was wonderful. Okay. So I really have only 3 areas that I'll be focusing this presentation on. I have 40 minutes. The first one is on context. Now, many of you have sat through a lot of presentations, and maybe context is not necessary for our group because we're all in this together, so to speak. But to me, it's extremely important to set the context for why this is important, why we need to move to evidence-based practice. All right? And then the second thing I want to do is expose you to theories. So by show of hands, how many operate out of theories right now? How many of you operate with theories? Theories? Little hand, 2 little hands. Okay, so this could be totally new to you, and you might say at the end of the day it's too theoretical. But if you're anything like me, when I got introduced to theories, I said, that's exactly what I'm doing. That is aquatics. That is exactly what we do at the facilities, and it's so obvious. And if you have that light bulb go off, which I hope you do, then theories are for you, because really what they are just sets of maps of how to think through things so you don't need to miss a lot of stuff. All right? And then the third part of this presentation is on applications. Specifically, I want to give a series of 3 examples as it relates to where you might be. If you're a practitioner right now, you might fit more into example 1 and 2, And for the 4 or 5 of you who raised your hand as researchers, the third example might be more applicable. But my goal for you is that some of you will, during the question and answers or reflection session, really be turned on to this and say, I want to start doing this, and I want to give you ways to get started. All right. So specifically, a lot of context, a lot of focus on health behavior, some examples, and ultimately, if all this is just for me speaking up here from the podium and being an academic, so to speak, it would not help any of us. So that's why I'm getting right into real-life settings. How many of you had a chance to read the article that was posted in the New York Times in 2012? And it had this picture, and it was in the opinions pages, and it was talking about drowning prevention and this huge need to do more for the African American and Latino population. None of you saw it? Well, this is the most basic level of evidence. If a national newspaper posts something, even if it's anecdotal, but it has statistics posting from the CDC, linking things to data, it is evidence. And it, at some level, is enough evidence to get funding. How many of you would like to get more funding for your programs? Just a few? Let's try that again. How many would like to get more funding? Yeah, that's what this presentation is about. Evidence-based practice is only as good as it will be if you can get more funding to do more of what you want to do, right? You become more credible. So this specific article allowed me to secure a grant for $100,000. This will be my first example when we get to it. I just want to get your attention. This is really powerful stuff. So what was so interesting about this article is that it spoke about mortality, morbidity, and health disparities. Now, I'm in public health, and so these terms from an academic perspective can seem really like, what does that mean? Okay? So we need to start talking like this, because when we start talking like this about what we do, we will get more money. So what is it? Mortality. Well, what do we know? 0 to 4. Mortality, the greatest cause for mortality death is what? An injury, accidents specifically, drowning. 0 to 4, the leading cause of mortality for children is drowning. Okay, well, let's look at morbidity. What is morbidity? Injury. But we keep talking about injuries, where the rest of the world is talking about morbidities. So we used to talk about morbidity. We get taken more seriously. So morbidity in the world of aquatics has to do with all the near drownings. All right? Or if we talk about chronic disease, that's morbidity. Okay? People are injured. That's morbidity. And health disparities. What's so powerful about talking about health disparities? Well, if you put hundreds of millions of dollars on the table, which is currently on the table, and you're not talking about health disparities, you're not getting that money. So health disparities is the factor that this article was highlighting, is that the African American population, the Latino population, are 6 to 8 times more at risk of drowning than the white population. Now, that should not be surprising to any of us, because the USA Swimming has been all over this the last year, right? But how many of you are getting money from Make a Splash right now? Well, I was talking to Sue Nelson with USA Swimming, and they have an incredible program that they specifically want to fund health disparities work, working with African American and Latino kids. So if you can show that you are working in health disparities, you can access money even within our own industry. But it's actually more powerful. Evidence-based practice is powerful not just towards drowning prevention, but chronic disease. And I see many in the room who are leading scholars in our field right now, and so I'm not speaking to anybody who's not unfamiliar with this field. We're people from other countries who are now setting up therapy centers because rehab in the pool is anecdotally very powerful. Anecdotally. we don't have sufficient research yet. The research that's out there is not good enough. All right? So what can we do? We can learn from Dr. Rimmer. Dr. Rimmer wrote an article in 2005 speaking about that. Where is this huge missing population? I came out of a presentation next door. Some of you were there. And we're talking about missing populations in the pool. Well, there's a lot of people who should be in the pool who are not currently in the pool. People with various kind of Parkinson's, stroke, these kind of rehab-based conditions, they don't know that they should rehab in the pool. All right? And he is, in this article, making the claim that the reason why people aren't in gyms is because it's too difficult to be exercising in gyms. Now, you all know that. You're all trying to make arguments for why they should be in the pool because we know it's low impact. But if you reference this article, you're actually making a claim that the reason why they're not in the gyms is because it's too high impact. So again, there's evidence that from a leading scholar who gets millions of dollars from NIH that these people aren't exercising on land because it's too difficult. So I'm just putting it here in basically front and center, what I've already talked to you about. There's this untapped potential for us to do more work. But we have to move away from thinking about just doing good work with swim lessons and arthritis foundation or whatever it is to framing us differently so we get taken seriously by the medical establishment. So that is the purpose of what I am trying to accomplish in this time span. So 2 more slides before I get into the second part of this presentation. It's so overwhelming. I said that to begin with. When I had been in this field for 2 years and I was seeing the potential, we were operating a warm water therapy pool in Palo Alto, and there was hundreds and thousands of people who were referred from the medical establishment, from the hospital, post-surgery, into the therapy pool because it had been around there for like 38 years. So it was an institution in the community. Still, there was a lot of naysayers. So where do you begin? When we know what we're trying to do is so complex. Well, we got to start by some type of evidence. And what is evidence? Well, evidence changes. What is evidence yesterday might not be evidence today. What was definitively true 10 years ago is not true today. So truth changes, and this is really important to know because a lot of really good research, randomized clinical trials we hear about, and I'm going to talk about later, is the gold standard for research. However, even in randomized clinical trials, what was true 30 years ago has been proven not true. So we mustn't think that we can't do research as practitioners. We can. But why don't we? Why don't we do research? Well, I would agree with what Dr. Lawrence Green has been arguing for a long time. It seems like a waste of time. It takes forever. It takes so much money. But can we hear from a few other people in the group, why are we not doing research? When we know what we're doing is so powerful. Yes?
Lack of time.
Lack of time. Takes a lot of time. Absolutely. Someone else? Lack of knowledge about how and what to do it. Absolutely. It seems like a daunting task. Lack of resources. Besides time, what could be other resources we lack? Staff and tools. What are tools? Measurement tools. I am going to cover all of these things. One more person. Yes, George? Yes. Extremely important. We are in a business of what? Operations. So if we're going to keep moving forward and get slightly better each year, we basically have to do a trade-off to do research. And that trade-off seems too high right now. Anyone else wants to say something? All right. So these are some of the many reasons. Well, you've said many of them, but quality of evidence. Comparing. You've heard that you need to do research that's comparative research. What are you comparing? You might have asked yourself that question. I did. Then somebody said, well, you can do research, but you don't have the right sample size. They throw at these jargons, and then you feel stifled. Because you need a statistician to determine sample size. You might not have a statistician. But it doesn't need to be this complicated. Last thing before I switch gear into the theory, I'm just warming us up. This is context still. These are a series of research designs. And what you see here is the gold standard on top in blue, randomized clinical trials. Why are these so powerful? Because they claim to be objective. All right? So you can't influence data. All right? But there are many other research designs. It doesn't need to be RCTs. And I think that's what we often forget in aquatic, particularly in our field. We forget that there are all these other ways we can do research. Yesterday, I sat in on Dr. Nolan's presentation. A leader in the field, thank you for being here today. What was the focus? It was observational studies, specifically case studies. We need to do more case studies. You have had cases which have been phenomenal. You need to not just talk about them to your colleagues. You need to write them down. It's just, carve out, take a vacation. You are pioneering this field, so you need to document it. Then you send it in to our own journal, and I am certain they will publish it. So this is the most basic. Your successes, document them. I'll talk about another way that you might not have heard about, and that is practice-based evidence with heuristic devices. And that is what this presentation is about. All right. What is a heuristic device? It is a roadmap. All right? It's a roadmap for how we believe things happen, almost like a domino effect. Yeah? So I'm going to show you some heuristic devices, and hopefully you'll get excited about them. Specifically, the heuristic devices I'm going to be talking about is I'm a behavioral-based scientist. All right? So I'm interested in understanding why are you doing what you're doing. Actually, I'm more interested in understanding why an organization is doing what an organization is doing. All right? And that gets to George's question of trade-offs. Because at the end of the day, some things are bigger than us. We might want to do research, but our executive director or CEO or board might not want to. So it's a trade-off element. And so at the end of the day, I'm interested in organizational behavior, but you might be interested in individual behavior. Yesterday in my presentation, I and all of you who were there, we learned about interpersonal heuristic devices with the continuum of care model, the Lytton model. All right? All right. The next series of slides, there's going to be 7 different heuristic devices introduced to you. This first one is so powerful. Everything I do, be it planning making a video, be it making a workshop, a continuing education training, be it implementing research on the ground, even hiring an important role, I use this planning model. This is called a pre-seed, proceed model. All right? And what it does, it's all those yellow boxes are a series of steps that we need to take in order for doing due diligence in our work. Due diligence. So what does that mean? So typically when we are planning something, we jump straight into it, don't we? And then we do it, and then once we're done with it, we say, that was good, and then we rest. The pre-seed pro-seed model is starting by saying you have to plan first. Not just you have to plan first, but you have to do an epidemiological needs assessment first. Now, you might not be an epidemiologist. I'm not either. But you can go on the CDC website and figure out what's the prevalence of drowning, what's the incident rates. These numbers are right at your fingertips. That's an epi assessment. It's basically figuring data to confirm what you're trying to do. So the pre-seed, pro-seed model I could talk about for a long time, but it's basically saying you first got to plan, then you got to do, and then you have to retweak. And instead of just saying those three terms, what we're looking at, hopefully the sound will work, is it goes in this order, and then you get to the health program. We do health. We all agree with that. You get to the health program, and then you come all the way back with the ultimate purpose of improving quality of life. My second goal for you is to be turned on to the idea that we work in the field of improving quality of life. Quality of life. What does this mean? Well, we often say that we have better range of motion, that our people feel better, that they're less depressed, all these things. They get back on their feet, they have better balance, they have better flexibility. Those are all good terms, but they're too small. People get lost in the details. But if you start talking about quality of life, you are entering into the universe of people who, this is a huge field. This is a movement that's only going to grow in the next 10 years. So quality of life. So the pre-seed, pro-seed model that was developed, early work in the 80s, then in the 90s finalized like this, knew back then that quality of life was going to be the way of the future. But remember, research takes 17 years. So now, 17 years later, here we are. The next conceptual model I would like to talk about is the ecological behavioral model. Now, many of you might be very familiar with this. It's been around for a long time. Bronfenbrenner out of Harvard did this work in the 70s. Why is this so powerful to us? Well, let me give you an example. Yesterday, I sat in on the presentation by Kim Burgess with the National Drowning Prevention Alliance. And she works, whether she knows it or not, in the ecological behavioral model. And if she were to say that, and she was to put that up on her website, all of a sudden more people, researchers and funders, would understand what she does at a whole nother level. So why does she work in the ecological behavioral model? Because her work is not just focused on one-on-one. It's not even focused on one in the group, like right now. No, it's focused on the community and driving policy change. And that's what we need more of. All right? So it's basically this idea that what you do one-on-one with a patient is great, but we need to go beyond that. We need to include the medical community. We need to include local and state government. Which brings me to the ICCC, Innovative Care for Chronic Disease Model from the World Health Organization. This model is extremely powerful. I base all my work out of this model. It's by Epping Jordan. She's available to you at a high fee, but she's worth every penny. What she did is she took a framework that was developed in the 80s, the evidence-based model, which will be the last slide I show, and she pushed it further. It's not just her, it's a whole institution, okay? But what's so powerful about this model is that it's basically saying that in order for us to get better outcomes for chronic disease, we need to make sure that we not just focus on the patient, but the patient and the families. We need to make sure we link the community partners and the healthcare team. In Aquatic, by and large, we operate out of community partners. That's where we fit. And we often clash with the medical community. It does not need to be this way in a continuum of care model. More so, we need to make sure that the community, by and large, is linking with the healthcare organization in these specific ways. And more specifically than that, we need to make sure that we work on all the elements that improves a positive policy environment. And here are outlines for what that means. So you can look at the model and say, is that true for my organization? Is that true for my community? And if it's not, you can see which one is kind of like the lowest hanging fruit and start working from there. So it's also very powerful that once you write a program plan and you can say that you're building your program plan out of the ICCC, it makes people, funders, philanthropists, scholars, understand that you understand the bigger contextual framework. And that's very powerful to create more community partners. Some of you said, well, the challenge is that I don't have the resources, I don't have the tools. Well, if you start talking about this kind of stuff, all of a sudden people start flocking to you because that's how scholars are talking. All right? Let me share a behavioral theory that you all know of. You might not know, but you all do know of this model. This is Prochaska's Stages of Change model, trans-theoretical model of change. This model is way outdated. I should say that models are only as good as, the time they were existing in. But still to this day, this model gets a lot of funding. Okay? It's actually not a model. It is a theory. So this is a good time for me to explain the difference between a planning model, that's a planning model, there are sequences of steps for administration, a conceptual model, this is also a conceptual model, this is showing the world how you have your philosophical orientation, and a behavioral model, behavioral theory specifically, which shows something that we talk about in science as constructs. Okay? Those are mechanisms for how change takes place. All right? So those three different types of planning models, you have to have one of each at least. But in either case, this is the most common behavioral theory. And when we talk about behavioral theory, the majority of behavioral theories are individual-based and has been for a long time. It's just in the last few years that we moved to other types of theories. But this theory is basically, maybe the best way to think about it for us is exercise, whether it's for yourself or your patients. Think about it. How do we get people into our centers? Well, it has to begin with some pre-contemplation. In order for them to pre-contemplate coming to you, they have to be exposed. So now you can start thinking about how can you create that exposure. Next, they need to be in contemplation phase. And during contemplation phase, they are going to have different needs. They will have different needs than during the pre-contemplation phase. In other words, change doesn't just happen. A person doesn't just wake up tomorrow and say, I'm going to start running a marathon, or I'm going to be a kickboxer. No, there's a sequence of steps that takes place. And so this is some old model, but it's still a very powerful theory of how people think about changing their behavior one step at a time. And the idea is, for each one of these boxes, in order to go, you can go both ways. You could be in maintenance state, and then there's the next one, which is like relapse. And you can also come out of relapse, be it drinking or exercise, and you can go back onto your maintenance schedule, right? So you are fluent between these steps, but what the theory is saying is that for each one of these steps, you have to have a very different communication strategy to hook the person. Does that make sense? And for each stage, what about if you were able to take 100 people in your program, but whether they're active or inactive, and determine where they fit on this? Right? Maybe a lot of them are in preparation phase. In other words, they were in action and maintenance, but they went back into preparation for whatever reason. Maybe they had a surgery. Now they're trying to get back in, but they're just preparing themselves psychologically. So anyway, it's an old theory, but still good for illustration purposes. And I still use it. I got a community benefit grant because I relied on this theory. Medical physicians love this theory. All right. This is another theory which I'm extremely attracted to. The prior model was using a sampling frame of individuals. Like we're looking at the individual. How do individuals change? This specific theory is very new, out of UNC with Dr. Brian Weiner. All right? And he's a specialist in how does organizations change. right? So you need to have your organizations change in order for you to do that trade-off, to do more research, or even to begin research. So this is a model that basically is proposing how that change can occur. And so for each box, it's going to take certain things. And so some of you might have heard about change efficacy. Like I might have efficacy for doing yoga right now. I do. I did yoga before my presentation. I don't have efficacy for running right now. Okay? So in other words, I don't have the motivation and the readiness to do one thing, but I have it for another. So efficacy is task-specific, okay? And so he's borrowed from an individual theory to construct an organizational theory. Very powerful. Now, I might have lost some of you, and that's not the purpose, but I'm trying to expose you to how powerful these are. And I encourage you to start reading about individual-based theories to begin with. I'm back to the beginning. And I told you that Epping-Jones, with the conceptual model that I used, the ICCC, she built on the evidence-based model. Many of you have seen this in one way or another. How many people are PTs in the room? Awesome. PTs are like my favorite type of professionals in the aquatic field because they are so ahead. They're so ahead. They're totally on board with community-based health, with chronic disease. All of this is like, this is the time for physical therapists. Your time has arrived. And so this type of evidence-based practice is very powerful to the medical establishment because back in the day, what we used to do is we used to trust the physician 100%. Whatever the physician said, we were going to do. But evidence-based practice is saying we shouldn't just trust the physician. There's 3 parts to making a decision. 3 parts. We have to have clinical insight, absolutely. We also have to have research insight, whatever the research is documented to say, because sometimes the physician or the physical therapist isn't up to speed for what the research has shown. And we have to include the patient's values. We have to make it patient-oriented care. All right? So you want to always reference this SACIT if you are trying to get funding, because everyone knows of this work, right? Okay, which leads me to, I've been doing a lot of thinking about all these theories, and I'm proposing an aquatic planning roadmap. This roadmap is very simple. It's basically saying that in order for us to move aquatic community health, that's kind of the overarching theme that I think that we all operate within. I was trying to get away from aquatic therapy because some of it is fitness, all right? Aquatic community health. To move aquatic community health forward, to get to health outcomes, which are quality of life measures, we have to input some data, to speak like an IT person, but we have to have certain business objectives, and this is often missing in theories. And we have to have process outcomes. These are short-term, task-oriented goals, all right? And so what do we need to input? Well, we need to input the evidence-based framework, patients, physicians, and caregivers. We have to have workforce development, so maybe you fit in that if you're improving, IG or AquaStretch or whatnot. We have to work on facility access. There's a lot of people here for that. We have to get seed funding. We have to develop our curriculum. It's a huge problem in our field. We don't develop enough curriculum, so we are testing things that aren't testable. And we have to have healthcare partners. With this input, we are trying to move forward business. Business is to increase usage. I was talking to the CEO of Councilman, just like a leading consulting firm in our field, and I asked, what's your outcome measure? He says usage. But it's more than usage. We know that. What's beyond usage is adherence. It is through adherence we get outcomes. People have to keep doing it. We have to improve evaluation. We even have to evaluate. So you have to start evaluating tomorrow and get better at it. And we have to increase communication Because unless we start communicating a different message, people aren't getting it. And that brings us to process outcomes, which are directly tied to these. And I think if we move this forward, we are going to have much greater success in convincing our community partners that we are in this and we're serious about it. Which brings me to the third part of my presentation, which are examples. And I have about 8 minutes. Yeah, okay. So if you are a practitioner right now and you're saying to yourself, how can I get started? You can get started right now with trying to think about moving operations to research and development. Every business needs to have research and development. And you need to argue with whoever's your higher-ups that you need to have a carve-out. 5% of your funding to research and development. Okay? So this is your first challenge. Because if you do, you can tell them there will be benefits coming with it. There will be return on the investment, which will be funding. Here's the first example. I told you earlier that I got $100,000 from the drowning prevention grant. Why? Because I linked the ICC framework to specific EPI constructs. In other words, I said that we have a mortality problem in this country. The second leading cause of injury death happens from drowning. I then said we have a health promotion opportunity. And that's what we want to do. We want to create a program about that. So what is the program? I explained what the program was. But see, too often what we do in our field is we jump straight to the program without the first part, which makes people lost, or we are lost in translation. For interest of time, I'm going to jump ahead. You might be further along, and you might already be doing this. That's great. And if that's the case, you want to get a little bit better. I want to remind you that 5 years ago, I wasn't doing any of this. And that's when I had that aha moment. Okay? And I went to get myself an MPH, so I learned the tools that I'm sharing with you today, and then now we are doing this, right? So that is basically securing evidence from a newspaper. That was all it took. Next, now this is an example of a replication study. So basically, what I'm working on as research and development is creating the nation's first course, associate degree in aquatic hydrotherapy. All right? So we have been doing 2 years of evaluation of a 16-hour segment course, all right, tailored to chronic disease. So the first year we did a stroke, and it's published here, if you would like to, in the Journal of Interprofessional Care, international journal. I'm very excited. It was my first author paper. And then in this January, we did the second intervention, keeping everything the same, and this time we were tailoring it towards children with CP and Down syndrome. All right? So we were measuring and evaluating this specific intervention, and then somebody said to me at a conference, since you're doing replication studies, that never happens. And it's true. Most times it's one study and it never gets scrutinized. So I did a comparison. And so here's the comparison. So basically, the first intervention was basically the O means an observation, X means the intervention, okay? So the first time we did it very basic because we didn't know what we were doing. Second time, we got better because we were comparing and improving slowly. So anyone can look from this that we got a lot better. It's a much stronger research effort. But look, the budget was the same. And that happens because we're getting better, so it takes us less time to do something. Okay. The third, for those of you who are researchers in the room, I am calling upon you, I hope that you are interested in this, that is to start implementing validated instruments. Right now in the aquatic field, it is a drought of instruments. There's examples in the Adapted Aquatics booklet in the back of some instruments, but they're not validated. Then it's not good. The first two efforts I was giving examples of, I wasn't using validated instruments either. But if you're further along, start using validated instruments. And there comes the challenge. They don't apply to us. They don't ask the right questions. But my challenge to you is to think about using health-related quality of life instruments. There's about 120 of them out there. Pick any one, all right? But better yet, pick the NIH Promise Instrument. We did, and we got seed funding from community benefit for it. This is highly attractive to the NIH. NIH has basically compiled all 120 instruments into one online instrument, which you basically can then, if you're a researcher, pick which specific modalities you're assessing. There's 9 for in Promise, and there's 5, I believe, for neuro quality of life questions. So our specific intervention, we chose 6 from the Promise instrument and 1 from the neuro condition, compiled it into one. It's a 15-minute online survey that we're now administering through iPads, all right, directly on the pool side to people, and it goes into a data bank. You don't even need to worry about, HIPAA and floating documents around. It goes into their database, and then there you have it, a baseline. And you can then do analysis. And that is what we did and are doing, and we are basically going to also follow up with post-tests at the end of a set segment, all right? But I don't recommend you starting here. You can do whatever you want to. But for me, what worked for me was I got my feet wet, so to speak. Started experimenting with this, started building my teams, working with researchers, all right? And now this is where we're at, and I have great promise for great hope for what we can evaluate. We're specifically looking at Parkinson's patients, arthritis patients, fibromyalgia patients, Guillain-Barré patients, and so forth. We're seeing hundreds of people, so if we do a 6-month pre-post or 12-month pre-post, we're going to have some really nice sample sizes. Okay. Thank you for your time and attention. I would really appreciate if we could have a dialogue and feedback.
Okay, we do have about 5 to 7 minutes for questions. I'll be happy to move the microphone along while we're waiting. Oh, okay, great.
I would like to challenge all of the clinicians in the room, write it up, okay? If you don't know how, every single PT faculty member in the country, and there's more than 200 PT schools, have to do research. We have to have a scholarly agenda. Ask us. We know how to do it. We can help you do it. And if your local one won't help you, just call me.
Yeah, can I comment upon that? There's a lot of people in the PT faculty very open to research. There's also in the public health arena, health promotion is where my field is. We would love to get into this field. And there's a lot of, it's unusual that adjunct faculty will have time to do research, but look for assistant professors. Go and meet with them. Just show up on their door. They'll never respond to your email likely because they're so busy. But if you knock on their door and say, listen, I really want to do this. Are you interested? I would do most of the grunt work. I just need your expertise in X, Y, and Z. They are all on board for it because they need at least 5 publications in order for them to get tenure. So it's really dire for them to do research, and they don't know how to partner with you. So the key is for you to go and find them.
Marty mentioned yesterday she's working with a medical group now on an intervention. Marty, would you mind? How did you get involved in that?
I got involved just because I was interested. I basically didn't know what I was doing, and have been coming to the conference. But what it was is one of the docs had read this. Docs are now not only encouraged, but they are forced through Medicare to do some functional evaluations in their office and make that part of their data. And so it's a doc that we've worked with in the past, and he said, what do you use as functional tests that are going to be easy because I only have so much time? And so we sat down and just talked about it, and then he said, well, you're doing this in the water. Why don't we see what we can accomplish? I'll do the testing as far as in the office, and I'll just basically say, folks, go there, and then you can do any of the tests that you want, and we'll talk about it. So that's how we actually got started. And as far as funding, we do not have funding at this time, but it kind of just evolved. I mean, it wasn't something that I sat down and said I should think about for funding of this. It just has evolved. And I'm sure that I'll be calling on you, Dr. Dalney, and also you, Janet, to help when I get to the point where I need to write this up. So thank you.
Great. Can I comment upon that? So I think that the key in PT, that's absolutely true. There's been a huge shift in Medicare that you do now have to document. And, they're going to not, in this country, we're not so good at regulating. So it might take a while before it gets down on you. But why not start now? If you find a researcher and you expose, they might not have heard about Promise. Very few people have. We're the first in the country to implement it in community-based setting. But the point is, if you ask your researcher to implement Promise for you as a physical therapist, it is a far superior instrument than a single functional instrument because it's a compilation of the best. It's more than, I don't want to quote, but more than 40 specific faculty whose work, the nation's leaders in instruments, psychometric evaluation, who've come up with Promise because we know there's too many instruments and it's so difficult to say, well, is this one good, is that one good, back and forth. So this is some better way to go. And the best pitch for it, I don't get paid to say this, but is that it's computer assisted. So in other words, it will go through a series of algorithm. So it will just be 15 questions, but based on how they answer the first question will determine the next question what is asked. It's very powerful.